College of Medicine, please.
Thank you very much. Spine infections in children. It's a real pleasure for me to come to home. I'm going to call this home, although I'm not sure it is, but my grandfather was born and raised in Norrby, and I've talked to a lot of Swedes, and nobody's ever heard of it. And so if there's a Swede in the audience that's heard of Norrby, could you raise your hand? I've never heard of anybody. Anyway, it's only about 2 hours from here by car. It's just south of Kisa, so it's close to here. And I visited there a few years ago, and so it's a real pleasure for me to come back. So I'm going to start with my most recent infection. This is a 13-year-old boy with arthrogryposis. He was a non-ambulator, and I operated on him in 2004. I think his curve was about 70 degrees or so when I did him. And this is a radiograph from about 3 years or so post-op, and everything was going fine. And then last fall, he showed up with a little bleb in the inferior part of his incision. It looked like just a little, not a pustule, it looked like a little, a bleb, I guess is the best word. He had no pain, a little discomfort, and then as you might guess, it subsequently drained. We had a discussion about removing his rods, and he preferred to take Keflex. We actually scheduled him for surgery on December 23rd of last year. And his drainage stopped, and so he was happy and decided not to have surgery. And 6 months later, he came back draining again, and we discussed pros and cons again and removed his implants. And you can see here, this is one of his rods. This is the concave rod, and he's got a nice fusion mass. Everything appeared solid on that. We tracked the sinus tract down to this transverse traction device at the inferior part of the incision, which is where it was coming from. This device was a little bit loose. We removed everything. Post-op, he did fine, and we closed him primarily, which is what I think you can do with these late infections. Well, is this the end of the story? Probably not. Is this curve going to progress? Probably yes. Will he need another surgery? I hope not. He's 19 years old, going on 20 soon, and there is a decreased risk of progression in mature patients. But it's well documented that these fusion masses can bend, and so even if he doesn't have a pseudoarthrosis, we got to keep an eye on him. Discitis, I think we've all heard of it. It's rare in children. It was originally thought to be an inflammation. I think we all agree now it's probably an infection. It can be a very difficult differential diagnosis. Lumbar spines are by far the most common. Brown, in his British Journal article, divided it up into 3 age groups: the neonate, the toddler, and then older children. By far the most common is the toddler. And early, in a nice review in the American Academy of Orthopedics Journal, or Surgeon's Journal, described this as one end of the spectrum of spondylodiscitis. And I really like that definition because discitis itself usually has an excellent prognosis. Spondylodiscitis in adolescents and adults has a much more guarded prognosis. And I think it relates to the etiology. If you look at the hematogenous blood supply, in children or young children, the vessels cross the vertebral end plate and terminate in the disc. So really, I think we have a combination of a vertebral osteomyelitis as well as a disc space infection. And then as they get older, the vertebral, and in these younger patients, the vertebral blood supply is capacious and it eradicates the infection from the bone, but it doesn't get to the disc so well. So the infection stays in the disc, hence the term discitis. In the older patients, it's the same etiology as the hematogenous infection, but now there's less collateral circulation. The decreased blood supply fails to eradicate the infection from the bone or the disc, and so now we got a term spondylodiscitis. Children, especially these toddlers, often present late. They refuse to walk or they limp. They have back pain or abdominal pain. It's a difficult differential diagnosis. They usually will hold their lumbar spine straight, so decreased lordosis. Fevers to 37 or 38, 38 and a half. Back straight. Sometimes if you have them picking up an object from the floor, they won't bend their back. Difficult differential diagnosis. Laboratory studies are not very helpful, except for the SED rate is elevated about 80% of the time. CRP maybe 40% of the time. The CRP can be helpful if it's elevated to follow treatment. On the x-rays, we see decreased disc height. And this is present about 60 to 90% of the time. We're not doing bone scans at our place anymore for this, but it's well described in the literature that these will be positive on bone scan. MRI is by far the most sensitive test. It's positive early, it's positive before the x-rays change. It can be very valuable if the child is not responding to treatment. It helps us detect surgical lesions such as an abscess or bone destruction. Differential diagnosis is tough. It can vary anywhere from an abdominal problem to Scheuermann's kyphosis in the older patients or Schmorl's nodes. Leukemia should always be in the back of your mind in these kids. Vertebra plana and tumors we're going to hear about a little bit later on this morning or this afternoon, and osteoid osteoma. In the United States, it's Staph aureus and Streptococcus most of the time. Kingella kinga is becoming something that we're talking about a lot of now in the United States, especially in Vermont. Globally, we're going to hear about tuberculosis and salmonella and brucellosis. Kingella kinga is increasingly being detected in the United States. It's young boys, 6 to 24 months. They usually have a mild concomitant illness, often involving the mucosal membranes. It's usually a benign disease, like most discitis. The exception is it can cause a life-threatening endocarditis requiring urgent heart surgery. In Vermont, we're seeing a definite increased frequency of community-acquired MRSA right now, methicillin-resistant Staph aureus. We're also seeing a significant increase in methicillin-sensitive Staph aureus in our hospital. The hospital-acquired methicillin-resistant Staph aureus is stable. I think it's markedly decreasing. I've not seen one of these in quite a while. I've talked to our adult spine people, and they think it's pretty stable right now, but it's certainly not increasing in our place. Biopsy for discitis in kids? I don't think so. It's been done. Cultures are positive about 30 to 60% of the time, and that's usually staph. And so I think I would recommend a biopsy myself for children who are not responding appropriately to treatment. Treatment, body cast, has a high success rate. I did this back when I was a resident. I think nowadays that we realize it's probably an infection or is an infection. Nowadays we treat them with antibiotics, an anti-staph medicine, or as was just mentioned, a gentleman from India, that an antibiotic that would cover the local flora or the local problems. Expect rapid resolution in 2 to 4 days in discitis, and continue the IV until they're changing and they're clinically improving, and then switch to POs. We would only do POs for 4 to 6 weeks. Some institutions would go as long as 3 months. Surgery is rarely required. Indications would be an immunocompromised patient, significant vertebral destruction or instability, which would be very unusual. Epidural abscess in the neonate might require this, and progressive neurologic symptoms. Again, it's usually benign. Most people would recommend to follow these for a year. You can re-x-ray them if there's any question. Usually the disc will actually reconstitute. This is from Kaiser's study in spine, and the disc doesn't always reconstitute. This is 12 years later, and you can see there's a focal kyphosis from a prior discitis. Spondylodiscitis is different in adolescents and adults, and I like Early's summary of that, stating that it represents the other end of the spectrum of spondylodiscitis. The prognosis is still satisfactory in adolescents. It's still satisfactory in adults, but much more guarded. Spondylodiscitis in adults is associated with comorbidities, cancer, drug and alcohol abuse, diabetes, immunosuppression, COPD. They'll actually present with neurologic findings anywhere from 10 to 20% of the time, and the mortality rate somewhere between 5 and 15% depending on the article. CT-guided biopsy in this situation may help with the differential diagnosis in older patients with comorbidities. It may rule out cancer. In the case of spondylodiscitis or infection, it may actually identify the organism in patients who are not responding to treatment. So I think you'd have an increased chance of thinking about a biopsy on the older patient. Enoch study, 103 patients had CT-guided biopsies for suspected disc-based infections. They found malignancy in half of them. Discitis in 28%, and in the discitis patients, the biopsy actually changed the treatment in 36%. Karademus looked at 163 patients with spondylodiscitis, and it involved the lumbar spine most commonly, as we see in children. 70% got antibiotics, and 93% were treated with surgery, 56 with a posterior decompression, and 37 with a posterior decompression and stabilization. And I just realized that our president here at CCOT is one of the co-authors of this article. It's a Danish article from 2008. They found associated lesions of the neurologic findings were most associated with lesions involving the thoracic spine and C-spine and not the lumbar spine. 22 of 145 patients presented with neurologic findings in this study, which is 15%. The indications for surgery were bone destruction with increasing spinal deformity, almost always kyphosis, epidural abscess, neurological deterioration, and failure of non-operative treatment. The results of the non-operative patients, again, these are older, still 62 of 70 patients, 89% had a successful treatment with antibiotics, 8 failed and required surgery. Decompression, 32 of 56, only 57% had a successful result. 24 failed, requiring repeat surgery, usually for kyphosis. And you can see that here. Again, the anterior wedge deformity. Decompression and stabilization, they had 31 of 37 patients, 84% had a successful result, only 6 requiring repeat surgery. So, in summary, for this, in the older patients, treatment is still non-operative with antibiotics and rest. Our spine service at the University of Vermont is bracing these patients. I'm not sure how many of them actually wear them, but that's their recommendation. We'd expect 90% to recover. Consider a CT-guided biopsy if the diagnosis is uncertain or if they're not responding to treatment. Operative treatment, probably a decompression and stabilization is required, not just decompression. This is for failure of non-operative treatment, neurological deterioration, bone destruction with deformity, or an epidural abscess. Finally, we're going to talk about surgical site infection, which is a huge topic in the United States right now. The government is reporting 780,000 cases per year at a cost of $4.5 billion. It's the second most common sentinel event, or what they call adverse event right now in our situation. The first is hospital adverse drug events. 88,000 deaths per year are attributed to this, and obviously the increased risk is with comorbidities and prolonged surgery. Infection after spinal fusion now is pretty well correlated with comorbidities. In idiopathic scoliosis, a 0.5% rate of infection, cerebral palsy 12, myelomeningocele 17, and in this study by Cahill, polio was up at 33%. So we clearly know preoperatively that there's very different risks for different patients. And Hatlin's study from the University of Washington looked at spinal infections in myelomeningocele patients, 59 patients that had a spine fusion, and they found a high frequency of preoperative urinary tract infections and high frequency of decreased nutritional status or malnutrition, and recommended addressing these two problems before embarking on surgery. I really think in the future we're going to have, the government is going to be telling us about whether or not we should be operating on some of these patients that are at very high risk, just like the airplanes didn't fly during those volcanoes most recently, because they knew there was an increased risk. Surgical site infection is now being divided into 2 groups: early, less than 90 days, late, more than 90 days. The early, we can treat with multiple debridements with this new VAC dressing that became available about 15 years ago. And instrumentation removal is not required, and we do a delayed closure. The late, which is my opening patient, can be suppressed with antibiotics just like it was in him, but there's a very high recurrence rate just like it was in him. Instrumentation removal is required, and the wound can be closed primarily. The early post-op infection has been revolutionized with the VAC dressing. It's changed everything as far as I'm concerned. Canavessa's study, with 33 patients that had a spine fusion, they had an average, their VAC dressings were changed every 3 to 4 days, and only 1 patient had to have their implants removed. Late post-op infection, different entity, frequency anywhere from 2 to 7%. The wound looks nice, just like my patient did. There's pinhole drainage, usually going to a part of the instrumentation. It's aggravated by activity. Pain is rare, but discomfort is not unusual. Blood studies usually are negative, but the ESR may be positive. X-ray is usually normal. Etiology, is it the seeding of the surgical field at the time of the operation? I never thought so, but Fred Dietz from the University of Iowa did clean wound cultures in elective orthopedic surgery, and the cultures were positive in 58%, and these were the same skin flora that we're seeing in these late infections: Staph epidermidis and Propionium bacterium acnes. Is the etiology hematogenous? Less likely, and I'm convinced now that it probably is not. There's also a glycocalyx that forms around a membrane around the bacteria adjacent to the implants, which results in very poor antibiotic penetration, macrophage resistance, and difficulty in obtaining cultures in these patients. Treatment, Hedequest in Boston attempted implant retention in 26 patients, and they had an average of 3 vac dressings per patient and an average of 4 surgeries per patient related to the infection, and no patient cleared this infection without implant removal. Again, these are late surgical infections. Clark, in 1999, recommended as a complete removal of all of the instrumentation. Again, you usually do find the sinus tract leading to the instrumentation, and it's usually a loose part of the instrumentation, a blocker, or the transverse traction device. So the treatment, again, is you want to inspect for pseudoarthrosis. 72-hour cultures are usually negative. Steve Richards did a study looking at 7-day cultures and found that they were almost always positive. In that Clark study, they found 100% of their cultures were positive at 7 to 10 days. Primary wound closure, I didn't do it over drains in my case, but it's recommended over drains. Remove the drains early, and then postoperative antibiotics for maybe 7 to 10 days. Thank you.
Well, any questions? Please.
Dave, you know, we don't have a lot of infections in Cleveland, but I've always followed Larry Linke's principle. And Larry's was we open it, we pack it with betadine soap gauze, go back at 48 hours, change the dressings. 40 hours later, we close it over 2 drains, 1 superficial, 1 deep. And Larry's mnemonic is you suck, suck, and suck some more. So they stay in about a week, you know, until they're bone dry. And then I take them out. And I rarely would take out implants, except on the late infections.
That's true.
If they're 2-3 years out, yeah, you're just going to take it out. You don't need it anymore. Just get rid of it, and they're cured just by doing that alone. Although ID will tell you it's osteomyelitis. So.
Good point. Yep.
Please.
I'm Richard Gross from South Carolina, and have an exhibit out there in which I will appoint myself as a self-proclaimed king of post-operative late infections. Because in the series that we have out in the exhibit, 6 of 8 spina bifida patients got those. None of them were cured without removing the instrumentation, and the removal of the instrumentation led to a lot of further misery. So it's a
lot of further
problem.
what? I'm sorry?
And the crosslinks seem to be, as you said, a major problem. The second point I would make, having had 6 weeks of IV vancomycin, you can tell your colleagues of Vermont that spondylodiscitis patients will brace themselves.
Good point.
Henrik.
I was asking about the choice of implant material, stainless steel and titanium. In our institution, we're sort of down by using.
Go ahead, Dr. Gross.
Yeah, I've stopped stainless steel and everything. Some of the ones that we have re-instrumented with titanium or cobalt chrome have held up. I'm through with stainless steel for my life.
I think that's an important point because it's getting pretty well documented now that the risk of infection is much less with titanium than stainless. As of this moment, I'm still using stainless steel because I think I got a lot more power to correct with it. The titanium is much more supple and it bends, and if you got a 70-degree scoliosis and you want to take it down to 20, it's nice to have some power. So, but I think it's well documented in the literature now that titanium is a better choice for preventing infection.
One last comment.
Yeah, Dave, one other interesting thing about the late onset infections, we have maybe the last 10 over the last 5 or 6 years, 7 years, we've been doing nickel testing. They're all positive for nickel allergy. And whether or not that little inflammatory reaction is a precursor to infection, we're not sure. But there's something there when we start looking at the sensitivity. Maybe it's acquired, I don't know. And they were all stainless steel.
Good point.
Well,
Okay, thank you.
To move on, thank you.